So unfortunately, I lost about 7 pages of recording from 980 to the end of 986. So I'm just going to pick it right back up at 987. A patient with alcoholic cirrhosis often has protein-calorie malnutrition. Oral nutritional supplements containing protein from branched-chain amino acids that are metabolized by the muscles may be needed. These supplements provide protein that the liver can more easily metabolize. Parenteral nutrition, or EN, are used with severe cases of malnutrition. The patient with ascites and edema is placed on a low-sodium diet. The degree of sodium restriction depends on the patient's condition. Teach the patient and caregiver about the degree of restriction. Table salt is a well-known source of sodium. Other foods high in sodium include canned soups and vegetables, many frozen foods, salted snacks, e.g. potato chips, nuts, smoked meats and fish, crackers, breads, baking soda, olives, pickles, ketchup, and beer. Teach the patient to read labels for sodium content. Offer suggestions about how to make the diet more palatable. Seasonings like garlic, parsley, onion, lemon juice, and spices make food more appetizing. Collaborate with a dietitian about dietary strategies. Nursing management, cirrhosis. Nursing assessment. Subjective and objective data that should be obtained from a person with cirrhosis are outlined in Table 43.15. Nursing diagnoses. Nursing diagnoses for the patient with cirrhosis may include impaired nutritional status, ineffective tissue perfusion, activity intolerance, fluid imbalance. Planning. The overall goals are that the patient with cirrhosis will 1. Have relief of discomfort, 2. Have minimal to no complications, ascites, esophageal varices, hepatic encephalopathy, and 3. Return to as normal a lifestyle as possible. Nursing implementation, health promotion. Common risk factors for cirrhosis include alcohol use, malnutrition, viral hepatitis, biliary obstruction, obesity, and right-sided heart failure. Prevention and early treatment of cirrhosis focus on reducing or eliminating these risk factors. Urge patients to abstain from alcohol. Encourage those with chronic alcohol use to enroll in support programs that help patients maintain sobriety. Adequate nutrition, especially for the person who uses alcohol and other people at risk for cirrhosis, is essential to promote normal liver regeneration. Identify and treat acute hepatitis early so that it does not progress to chronic hepatitis and cirrhosis. Bariatric surgery for morbidly obese persons reduces the incidence of NAFLD. Acute care. Nursing care for the patient with cirrhosis focuses on conserving the patient's strength while maintaining muscle strength and tone. When the patient needs complete bed rest, implement measures to prevent pneumonia, thromboembolic problems, and pressure injuries. Modify the activity and rest schedule according to signs of improvement, e.g. decreasing jaundice, improvement in liver function studies. Anorexia, nausea and vomiting, pressure from ascites, and poor eating habits all interfere with adequate intake of nutrients. Oral hygiene before meals may improve the patient's taste sensation. Make between meal snacks available so that the patient can eat them at times when food is best tolerated. Offer preferred foods whenever possible. Explain the reason for any dietary restrictions to the patient and caregiver. Nursing assessment and care should include the patient's physical status. Is jaundice present? Where is it seen? Sclera, skin, hard palate? What is the progression of jaundice? If the pruritus accompanies jaundice, use measures to relieve itching. Cholestyramine and hydroxyzine atarax may help. Other measures to relieve itching include baking soda or moisturizing bath oils, alpha cari, lotions containing calamine, antihistamines, soft or old linens in control of temperature, not too hot and not too cold. Keep the patient's nails short and clean. Teach patients to rub with their knuckles rather than scratch with their nails. They cannot resist itching. Note the color of urine and stools and assess for improvement or normalization of color. When jaundice is present, the urine is often dark brown and the stool is gray or tan. Edema and ascites require your assessment and intervention. Accurate calculation and recording of intake and output, daily weights, and measurements of extremities and abdominal girth help in the ongoing assessment of the location and extent of the edema. Mark the abdomen with a permanent marker so that you measure the girth at the same location each time. Immediately before a paracentesis, have the patient void to prevent puncturing of the bladder during the procedure. Other nursing care associated with a paracentesis is outlined in Table 43.16. Dyspnea is a frequent problem for the patient with severe ascites and can lead to pleural effusions. A semi-Fowler's or Fowler's position allows for maximum respiratory efficiency. Use pillows to support the arms and chest to increase the patient's comfort and ability to breathe. Meticulous skin care is essential because the edematous tissues are prone to breakdown. Use an alternating air pressure mattress or other special mattress. A turning schedule, minimum of every 2 hours, must be adhered to rigidly. Support the abdomen with pillows. If the abdomen is taut, cleanse it gently. The patient will tend to avoid moving because of abdominal discomfort and dyspnea. Range of motion exercises are helpful. Implement measures such as coughing and deep breathing to prevent respiratory problems. The lower extremities may be elevated. If scrotal edema is present, a scrotal support gives some comfort. When the patient is taking diuretics, monitor serum sodium, potassium, chloride, and bicarbonate levels. Monitor renal function, blood urea nitrogen, serum creatinine, routinely, and with any change in the diuretic dosage. Observe for signs of fluid and electrolyte imbalance, especially hypokalemia. Dysrhythmias, hypotension, tachycardia, and generalized muscle weakness may occur with hypokalemia. Muscle cramping, weakness, lethargy, and confusion may be present with hyponatremia from water excess. Observe for and provide nursing care for any hematologic problems. These include bleeding tendencies, anemia, and increased susceptibility to infection. Assess the patient's response to altered body image resulting from jaundice, spider angiomas, palmar erythema, ascites, gynecomastia. The patient may have anxiety and embarrassment about these changes. Explain these phenomena and be a supportive listener. Provide nursing care with concern and encouragement to help the patient maintain his or her self-esteem. Bleeding varices. If the patient has esophageal and gastric varices, observe for any sign of bleeding from the varices, such as hematemesis and melena. If hematemesis occurs, assess the patient for hemorrhage, call the HCP, and be ready to transfer the patient to the endoscopy suite and or assist with equipment to control the bleeding. Maintain the patient's airway. Patients with bleeding varices are usually admitted to the ICU. Balloon tamponade is an option for patients who have bleeding that is unresponsive to band ligation and sclerotherapy. When balloon tamponade is used, explain to the patient and caregiver the use of the tube and how the balloon is inserted. Check the balloons for patency. It is usually the HCP's responsibility to insert the tube by either the nose or mouth. Then the gastric balloon is inflated with 250 ml of air, and the tube is retracted until resistance, lower esophageal sphincter, is felt. The tube is secured by placing a piece of sponge or foam rubber at the nostrils, nasal cuff. For continued bleeding, the esophageal balloon is then inflated. A sphygmomanometer is used to measure and maintain the desired pressure, at 20 to 40 millimeters of mercury. An X-ray verifies the balloon's position. Nursing care includes monitoring for complications of rupture or erosion of the esophagus, regurgitation and aspiration of gastric contents, and occlusion of the airway by the balloon. If the gastric balloon breaks or is deflated, the esophageal balloon will slip upward, obstructing the airway and causing asphyxiation. If this happens, cut the tube or deflate the esophageal balloon. Keep scissors at the bedside. Minimize regurgitation by oral and pharyngeal suctioning by keeping the patient in a semi-Fowler's position. The patient is unable to swallow saliva because the inflated esophageal balloon occludes the esophagus. Encourage the patient to expectorate and provide an emesis basin and tissues. Frequent oral and nasal care offers relief from the taste of blood and irritation from mouth breathing. Hepatic encephalopathy. Nursing care of the patient with HE focuses on maintaining a safe environment, sustaining life, and assisting with measures to reduce the formation of ammonia. Patients with HE may be confused and at risk for falls or other injuries. Assess the patient's 1. Level of responsiveness, e.g. reflexes, pupillary reactions, orientation. 2. Sensory and motor abnormalities, e.g. hyperreflexia, asterixis, motor coordination. 3. Fluid and electrolyte imbalances. 4. Acid-base imbalances. And 5. Response to treatment measures. Assess the neurologic status, including an exact description of the patient's behavior, at least every 2 hours. Plan your care of the patient based on the severity of the encephalopathy. In patients with altered levels of consciousness or whose airway may have been compromised, have emergency equipment readily available. Any GI bleeding may worsen encephalopathy. Institute measures to prevent falls or injuries. Control factors known to precipitate encephalopathy as much as possible, including anything that may cause constipation, e.g. dehydration, opioid drugs. Measures to minimize constipation are important to reduce ammonia production. Give drugs, laxatives, and enemas as ordered. Encourage fluids if not contraindicated. Assess the patient taking lactulose for diarrhea and excessive fluid and electrolyte losses. Ambulatory care. Patient with cirrhosis may be faced with a prolonged course and the chance of life-threatening problems and complications. The patient and caregiver need to understand the importance of continual health care and medical supervision. Supportive measures include proper diet, rest, avoiding potentially hepatotoxic OTC drugs, such as Tylenol in high doses, and abstaining from alcohol. Abstinence from alcohol is important and results in improvement in most patients. However, some patients find abstinence extremely hard and need emotional support. Explore your own attitude toward the patient whose cirrhosis is from chronic alcohol use. Always provide care without being condescending or judgmental. Treat patients with respect and concern for their well-being. Cirrhosis is a chronic disease. People can live many years with symptoms and complications from cirrhosis. The patient is affected not only physically, but also psychologically, socially, and economically. Major lifestyle changes may be needed, especially if chronic alcohol use is the primary cause. Provide information about community support programs such as Alcoholics Anonymous for help with chronic alcohol use. Teach the patient and caregiver about complications and when to seek medical attention. Include instructions about adequate rest periods, how to detect early signs of complications, skin care, drug therapy side effects, observation for bleeding and protection from infection. Referral to a community or home health nurse to help ensure patient adherence to prescribed therapy. Home care for the patient with cirrhosis focuses on helping the patient with activities of daily living while maintaining the highest level of wellness possible. Evaluation. Expected outcomes are the patient with cirrhosis will maintain food and fluid intake adequate to meet nutritional needs, maintain skin integrity with relief of edema and itching, have normal fluid and electrolyte balance, acknowledge and get treatment for a substance use problem. Acute liver failure. Acute liver failure, or fulminant hepatic failure, is a potentially life-threatening clinical syndrome. It's characterized by a rapid onset of severe liver dysfunction in someone with no history of liver disease. It is often accompanied by HE. The most common cause of acute liver failure is drugs, usually Tylenol. Other drugs that can cause acute liver failure include isoniazid, sulfa-containing drugs, and anticonvulsants. Drugs can cause hepatocyte damage by disrupting essential intracellular processes, causing an accumulation of toxic metabolic products. Other causes can include viral hepatitis, especially HBV. Hepatitis A is a less common cause. Outcomes depend on the cause. Cerebral edema, cerebellar herniation, and brainstem compression are the most common causes of death. Treatment of cerebral edema is described in Chapter 56. Liver transplantation is associated with a significant survival benefit in patients with a low probability of spontaneous recovery. Clinical manifestations and diagnostic studies. Manifestations of acute liver failure include jaundice, coagulation abnormalities, and encephalopathy. Changes in cognitive function are often the first clinical sign. Patients are susceptible to a wide variety of complications, including cerebral edema, renal failure, hypoglycemia, metabolic acidosis, sepsis, and multi-organ failure. Serum bilirubin is high, and the PT time is prolonged. Liver enzyme levels, AST, ALT, are often markedly increased. Other lab tests include blood chemistries, especially glucose, since hypoglycemia may be present and need correction, complete blood count, Tylenol level, screening for other drugs and toxins, viral hepatitis serology, especially HAV and HBV, serum ceruloplasmin enzyme synthesized in liver, and alpha-1 antitrypsin levels, iron levels, ammonia levels, and autoantibodies, ANAs, and ASMAs. CT or MRI can provide information about the liver size and contour, presence of ascites or tumors, and patency of the blood vessels. Interprofessional and nursing care. Since acute liver failure may progress rapidly, with hour-by-hour changes in consciousness, the patient is usually transferred to the ICU once a diagnosis is made. Planning for transfer to a transplant center should begin in patients with grade 1 or 2 encephalopathy because they may worsen rapidly. Early transfer is important because the risks involved with patient transport may increase or even prevent transfer. Stage 3 or 4 encephalopathy develops. Renal failure is a frequent complication of liver failure. It may be due to dehydration, hepatorenal syndrome, or acute tubular necrosis. The frequency of renal failure may be even greater with Tylenol overdose or other toxins with which direct renal toxicity occurs. Although few patients die of renal failure alone, it often increases the mortality risk and may worsen the prognosis. Protect renal function by maintaining adequate fluid balance, avoiding nephrotoxic agents, e.g. aminoglycosides and NSAIDs, and promptly identifying and treating infection. Monitoring and management of hemodynamic and renal function, as well as glucose, electrolytes, and acid-base status are critical. Conduct frequent neurologic evaluations for signs of increased intracranial pressure. Position the patient with the head elevated at 30 degrees. Avoid excessive patient stimulation. Maneuvers that cause straining or Valsalva-like movements may increase intracranial pressure. Assess the patient regularly for a baseline level of consciousness and orientation and report any changes to the HCP. Avoid the use of any sedatives due to their effects on mental status. The effects can be confused with worsening encephalopathy. Only minimal doses of benzodiazepines should be used due to their delayed metabolism by the failing liver. Closely observe the patient to prevent injuries and pad bed rails to avoid injury from possible seizures. Monitor intake and output for renal function and provide good skin and oral care to avoid breakdown and infection. Changes in level of consciousness may compromise nutritional intake. Many patients receive vitamin supplementation. Other factors, such as coagulation problems, may influence whether EN is started. An NG tube may be irritating to the nasal and esophageal mucosa and cause bleeding. Liver cancer. Primary liver cancer starts in the liver. The most common types of liver cancer are hepatocellular carcinoma, HCC, 75% of cases, and intrahepatic cholangiocarcinoma, bile duct cancer. In 2018, there were about 40,710 cases of HCC, 28,920 HCC deaths in the United States. Worldwide, liver cancer is the fifth most common cancer and second most common cause of cancer death. Liver cancer is the most common cause of death in patients with cirrhosis. Cirrhosis caused by hepatitis C is the most common cause of HCC in the United States, followed by NAFLD. About 2% of patients with cirrhosis develop liver cancer each year. In primary liver cancer, lesions may be singular or numerous and nodular or diffusely spread over the entire liver. Some tumors infiltrate other organs, such as the gallbladder, or more into the peritoneum or the diaphragm. Primary liver cancer often metastasizes to the lung. Metastatic cancer in the liver is more common than primary liver cancer. The liver is a common site of metastatic growth because of its high rate of blood flow and extensive capillary network. Cancer cells in other parts of the body are often carried to the liver via the portal circulation. Clinical manifestations and diagnostic studies. The manifestations of early liver cancer can be absent or subtle. They're often a result of the underlying cirrhosis rather than the actual liver tumors. The patient may present with hepatomegaly, splenomegaly, fatigue, peripheral edema, ascites, and other complications from portal hypertension. In late stages, patients will often have fever, chills, jaundice, anorexia, weight loss, palpable mass, and right upper quadrant pain. Diagnostic and screening for liver cancer are ultrasound, CT, and MRI. Recent advancement in MRI scanning have allowed for accurate diagnosis of liver cancers without the need for a percutaneous biopsy. Sometimes a biopsy may be done when the results of diagnostic imaging studies are inconclusive or tissue is needed to guide treatment. Risks of a biopsy include bleeding and potential tumor cell seeding along the needle tract. Therefore, a biopsy is generally not done unless a diagnosis cannot be made by CT or MRI and clinical presentation. Serum alpha-fetoprotein AFP levels combined with ultrasound have a high rate of detection of early-stage HCC. Interprofessional and nursing care. Prevention of liver cancer focuses on identifying and treating chronic hepatitis B and C viral infections. Treatment of chronic alcohol use may lower the risk for liver cancer. Screening for at-risk patients, e.g. those with cirrhosis, usually involves a combination of serum AFP and CT, MRI, or ultrasound imaging of the liver. Treatment of liver cancer depends primarily on the stage of cancer, number, size, and location of tumors, involvement of any blood vessels, patient age and overall health, and extent of underlying liver disease. Surgical liver resection, partial hepatectomy, offers the best chance for a cure. However, only about 15% of people have enough healthy liver tissue for this to be an option. The underlying cirrhosis and portal hypertension often compromise liver function and may cause liver failure after surgery. Furthermore, many patients are diagnosed at an advanced stage of cancer when surgery is not an option. For those patients who have early stage liver cancer and impaired liver function, liver transplantation offers a good prognosis. Non-surgical therapies include percutaneous ablation, chemoembolization, radioembolization, and sorafenib Nexivar oral therapy. In ablation, a thin needle is inserted into the core of the tumor. Then, various substances can be injected, ethanol, acetic acid, and the temperature of the probe, radiofrequency, microwave, cryotherapy, can be altered to destroy the tumor. This procedure can be done percutaneously, laparoscopically, or through an open incision. It is typically limited by the number, size, and location of liver tumors. It is usually offered to patients with early-stage liver cancer. Although complications are not common, they can include infection, bleeding, dysrhythmias, and skin burn. In patients with multinodular HCC or intermediate-stage liver cancer, embolization of the tumors is another intervention. There are two options typically used: transarterial chemoembolization, TACE, or transarterial radioembolization, TARE. TACE and TARE are minimally invasive procedures done by interventional radiologists. The catheter is placed via the femoral artery or radial artery and advanced to the arterial blood supply of the tumors in the liver. Either a chemotherapy drug, TACE, or radioactive beads, TARE, along with embolizing agents are then injected into the arteries of the tumor's region. TACE works by shutting off the blood supply to the tumors and exposing liver tumor cells to the chemotherapy agent. TARE destroys the tumors by slowly releasing radioactive material directly to the site of the tumor. It can take up to 3 months for complete results. In patients with advanced HCC, sorafenib Nexivar is typically the first-line treatment. It is a kinase inhibitor, a type of targeted therapy that blocks certain proteins, kinases, that play a role in tumor growth and cancer progression. See Table 15.13. This drug has the potential to slow tumor progression and prolong life. Nursing interventions focus on keeping the patient as comfortable as possible. Since these patients have the same problems as any patient with advanced liver disease, the nursing interventions discussed for cirrhosis of the liver apply to these patients. Although the prognosis for patients with liver cancer is poor, it is improving with early screening and surveillance programs for those with chronic hepatitis and/or cirrhosis. Cancer often progresses rapidly, with patients having complications from the advancing cancer and declining liver function. Without treatment, death may occur within 6 to 12 months, most often from hepatic encephalopathy or massive blood loss from GI bleeding. Liver transplantation. Liver transplantation has become an option for many people with end-stage liver disease or localized HCC. Liver disease related to chronic viral hepatitis is the leading reason for liver transplantation. Other reasons include congenital biliary abnormalities, biliary atresia, inborn errors of metabolism, sclerosing cholangitis, acute liver failure, and chronic end-stage liver disease. In 2018, 11,514 patients were listed for a liver transplant in the United States, with 8,250 patients undergoing a transplant. Liver transplant candidates must go through a rigorous transplant evaluation prior to being placed on the transplant list. This is done to confirm the diagnosis of end-stage liver disease and to assess for other comorbid conditions, e.g. cardiovascular disease, chronic kidney disease, that may affect the patient's surgical outcome. The evaluation includes physical examination, laboratory tests, CBC, liver function tests, cardiac and pulmonary evaluations, endoscopy, CT scan, and psychologic testing. Potential recipients receive counseling about cigarette smoking and alcohol abstinence. Contraindications for liver transplant include severe extrahepatic disease, advanced HCC or other cancer, ongoing drug or chronic alcohol use, and inability to understand or adhere with the rigorous post-transplant care. Liver transplantation is done using both deceased cadaver and live donor livers. The live donor liver transplant was first developed for children whose parents wanted to serve as donors. Today, some liver transplant centers are performing live liver transplant procedures for adults. In this procedure, the living person donates a part of his or her liver to another. However, the liver donation poses potential risks to the donor, including biliary problems, hepatic artery thrombosis, wound infection, post-operative ileus, and pneumothorax. Because of the limited number of donor livers, when a liver becomes available for transplant, it may be divided into two parts, split liver transplant, and implanted into two recipients. The decision to use a split donor liver is based on the donor's size and health. The recipients of the split liver generally are smaller than the donor. The success rate associated with split liver transplantation is somewhat lower than that associated with whole organ transplantation. Postoperative complications of liver transplant include bleeding, infection, and rejection. However, the liver is subject to a less aggressive immunologic attack than other organs, like kidneys. Transplants and immunosuppressive therapy are discussed in Chapter 13. Immunosuppressive therapy generally involves a combination of corticosteroids, a calcineurin inhibitor, cyclosporine or tacrolimus, and an anti-proliferative agent, e.g. azithromycin. Tacrolimus is superior to cyclosporine in liver transplantation. Standard immunosuppressive regimens often change over the course of the recipient's life. Corticosteroid withdrawal may be done and is relatively safe to do in liver transplant recipients. About 80% of patients live more than 5 years after liver transplant. Long-term survival depends on the cause of liver failure, e.g. localized HCC, chronic hepatitis B or C, biliary disease. Patients who have liver disease from hepatitis B or C often have reinfection of the transplanted liver. For patients with hepatitis B, treatment after surgery with IV HBIG and a nucleoside or nucleotide analog used to treat HBV infection has reduced the rates of reinfection of the transplanted liver. For patients with HCV, treatment with the new direct-acting antivirals, DAAs, that can cure HCV infection have provided the opportunity to use HCV-positive liver grafts. The need for a liver transplant may decrease in the HCV population. Research is ongoing to decide if DAAs should be started before or after transplant. The patient who had a liver transplant needs highly skilled nursing care either in an ICU or other specialized unit. Postoperative nursing care includes assessing neurologic status, monitoring for signs of hemorrhage, preventing pulmonary complications, electrolyte levels, and urine output, and monitoring for manifestations of infection and rejection. Common respiratory problems are pneumonia, atelectasis, and pleural effusions. To prevent these complications, encourage the patient to cough, deep breathe, use incentive spirometry, and frequently reposition. Measure the drainage from the Jackson-Pratt drain, NG tube, and T tube, and note the color and consistency of the drainage at regular intervals. The first 2 months after surgery are critical for monitoring for infection. Causes of infection can be viral, fungal, or bacterial. Fever may be the only sign of an infection. Adhering to the medication regimen can be hard, especially in the beginning. Emotional support and teaching for the patient and caregiver are essential to the success of the patient with a liver transplant. Gerontologic considerations. Liver disease in the older adult. The incidence of liver disease increases with age. The liver's size and metabolic breakdown of drugs decrease, and hepatobiliary function is changed. The liver has a decreased capacity to respond to injury. This especially applies to regeneration after injury. Transplanted livers take longer to regenerate in the older adult compared with the younger adult. Older adults are particularly vulnerable to drug-induced liver injury. This is due to several factors, including the increased use of multiple prescription and OTC drugs, which can lead to drug interactions and potential drug toxicity. Age-related decreases in liver function result in decreased drug metabolism and a decreased ability to recover from drug-induced injury. A growing number of older adults have chronic hepatitis C and the resulting cirrhosis. Antibodies to HCV and elevated liver enzymes may be found during a routine health assessment in asymptomatic patients. Lifetime health behaviors may influence the development of chronic liver disease in the older adult. Chronic alcohol use and obesity can contribute to cirrhosis, fatty liver inflammation, NASH, and liver failure. Because of many older adults' concomitant cardiovascular and lung diseases and possible anticoagulant therapy, variceal bleeding can cause significant morbidity and mortality and needs immediate medical intervention. In the older adult with liver disease, hepatic encephalopathy is sometimes misdiagnosed as dementia and often overlooked. Because older adults tend to have more comorbid conditions, transplantation may have more risks for complications. Therefore, older adults may not be good candidates for liver transplants. Disorders of the pancreas. Acute pancreatitis. Acute pancreatitis is an acute inflammation of the pancreas. Spillage of pancreatic enzymes into surrounding pancreatic tissue causes autodigestion and severe pain. The degree of inflammation varies from mild edema to severe hemorrhagic necrosis. Etiology and pathophysiology. Many factors can cause injuries to the pancreas. In the United States, the most common cause is gallbladder disease, gallstones, which is more common in women. The second most common cause is chronic alcohol use. This is more common in men. Other less common causes include drug reactions, pancreatic cancer, and hypertriglyceridemia, serum levels over 1,000 milligrams per deciliter. Biliary sludge and microlithiasis, which is a mix of cholesterol crystals and calcium salts, can be present in patients with acute pancreatitis. The most common pathogenic mechanism in acute pancreatitis is autodigestion of the pancreas. The causative factors injure pancreatic cells or activate the pancreatic enzymes in the pancreas rather than in the intestine. This may be due to reflux of bile acids into the pancreatic ducts through an open or distended sphincter of Oddi. This reflux may be caused by Blockage created by gallstones. Obstruction of pancreatic ducts results in pancreatic ischemia. The exact mechanism by which chronic alcohol use predisposes a person to pancreatitis is not known. We think that alcohol increases the production of digestive enzymes in the pancreas. The pathophysiologic involvement of acute pancreatitis is classified as either mild pancreatitis, also known as edematous or interstitial pancreatitis, or severe pancreatitis, also called necrotizing pancreatitis. In severe pancreatitis, about half the patients have permanent diseases in pancreatic endocrine and exocrine function. Patients with severe pancreatitis are at high risk for developing pancreatic necrosis, organ failure, and septic complications, resulting in an overall fatality rate of 5%. Clinical manifestations. Abdominal pain is the main manifestation of acute pancreatitis. Pain is due to distension of the pancreas, peritoneal irritation, and obstruction of the biliary tract. Pain is usually in the left upper quadrant, but it may be mid-epigastric. It often radiates to the back due to the retroperitoneal location of the pancreas. Pain has a sudden onset. It is described as severe, deep, piercing, and continuous or steady. Eating worsens the pain. It often starts when the patient is recumbent. Pain is not relieved by vomiting and may be accompanied by flushing, cyanosis, and dyspnea. The patient may assume various positions involving flexion of the spine to try to relieve the severe pain. Other manifestations include nausea and vomiting, low-grade fever, leukocytosis, hypotension, tachycardia, and jaundice. Abdominal tenderness with muscle guarding is common. Bowel sounds may be decreased or absent. Paralytic ileus may occur and causes marked abdominal distension. The lungs are often involved with crackles present. Intravascular damage from circulating trypsin, a proteolytic enzyme, may cause areas of cyanosis or greenish to yellow-brown discoloration of the abdominal wall. Other areas of ecchymoses are the flanks, gray Turner's spots or sign, a bluish flank discoloration, and the periumbilical area, Cullen's sign, a bluish periumbilical discoloration. These result from seepage or blood-stained exudate from the pancreas and may occur in severe cases. Shock may occur from hemorrhage into the pancreas, toxemia from the activated pancreatic enzymes, or hypovolemia due to fluid shift into the retroperitoneal space, massive fluid shifts. Complications. The severity of acute pancreatitis depends on the extent of pancreatic destruction. Acute pancreatitis can be life-threatening. Some patients recover completely, others have recurring attacks, and others develop chronic pancreatitis. Two significant local complications of acute pancreatitis are pseudocyst and abscess. A pancreatic pseudocyst is an accumulation of fluid, pancreatic enzymes, tissue debris, and inflammatory exudates surrounded by a wall next to the pancreas. Manifestations are abdominal pain, palpable epigastric mass, nausea, vomiting, and anorexia. The serum amylase level is often high. CT, MRI, and endoscopic ultrasound, EUS, may detect a pseudocyst. The cysts usually resolve spontaneously within a few weeks but may perforate, causing peritonitis or rupture into the stomach or the duodenum. Treatment options include surgical drainage, percutaneous catheter placement and drainage, and endoscopic drainage. When a pseudocyst gets infected, a pancreatic abscess results from extensive necrosis in the pancreas. It may rupture or perforate into adjacent organs. Manifestations of an abscess include upper abdominal pain, abdominal mass, high fever, and leukocytosis. Pancreatic abscesses need prompt surgical drainage to prevent sepsis. The main systemic complications of acute pancreatitis are cardiovascular and pulmonary, pleural effusion, atelectasis, pneumonia, and acute respiratory distress syndrome, ARDS. Pulmonary complications are due to the passage of exudate containing pancreatic enzymes from the peritoneal cavity through transdiaphragmatic lymph channels. Enzyme-induced inflammation of the diaphragm occurs, with the result being atelectasis caused by reduced diaphragm movement. Trypsin can activate prothrombin and plasminogen, increasing patient's risk for intravascular thrombi, pulmonary emboli, and DIC. Hypotension can occur from fluid shifts and sepsis. Tetany, which can be caused by hypocalcemia, is a sign of severe disease. It is due in part to the combining of calcium and fatty acids during fat necrosis. We do not understand the exact mechanisms of how or why hypocalcemia occurs. Patients with severe acute pancreatitis are at risk for abdominal compartment syndrome from intra-abdominal hypertension and edema. Diagnostic studies. Primary diagnostic tests for acute pancreatitis are serum amylase and lipase. The serum amylase level is usually high early, stays high for 24 to 72 hours. Serum lipase level, which is high in acute pancreatitis, is an important test because other disorders, e.g. mumps, cerebral trauma, renal transplantation, may increase serum amylase levels. Other serum findings include an increase in liver enzymes, triglycerides, glucose, and bilirubin, and a decrease in calcium. Diagnostic evaluation of acute pancreatitis is directed at determining the cause. An abdominal ultrasound, X-ray, or contrast-enhanced CT scan may identify pancreatic problems. CT scan is the best imaging test for pancreatitis and related complications, such as pseudocysts and abscesses. ERCP is an option, although ERCP can cause acute pancreatitis, along with EUS, magnetic resonance cholangiopancreatography, MRCP, and angiography. Chest X-rays may show atelectasis and pleural effusions. Interprofessional care. Goals of interprofessional care for acute pancreatitis include 1. Relief of pain, 2. Prevention or alleviation of shock, 3. Reduction of pancreatic secretions, 4. Correction of fluid and electrolyte imbalance, 5. Prevention of treatment of infections, and 6. Removal of the precipitating cause, if possible. Conservative therapy. Treatment of acute pancreatitis is focused on supportive care, including aggressive hydration, pain management, management of metabolic complications, and minimization of pancreatic stimulation. Treatment and control of pain are very important. IV opioid analgesics may be given. Pain medications may be combined with an antispasmodic agent. Atropine and other anticholinergic drugs are avoided when paralytic ileus is present because they can decrease GI mobility, making the problem worse. Other drugs that relax smooth muscles, spasmolytics, such as nitroglycerin or papaverine, may be used. Supplemental O2 is used to maintain O2 saturation greater than 95%. In patients with severe pancreatitis, serum glucose levels are closely monitored for hyperglycemia. If shock is present, blood volume replacements are used. Plasma or plasma volume expanders, such as dextran or albumin, may be given. Lactate ringer solution or other electrolyte solutions can correct fluid and electrolyte problems. Central venous pressure readings can help determine fluid replacement requirements. Vasoactive drugs such as dopamine may be needed to increase systemic vascular resistance in those with hypotension. It is important to reduce or suppress pancreatic enzymes to decrease stimulation of the pancreas and allow it to rest. This is achieved in several ways. First, the patient is NPO. Second, NG suction may be used to reduce vomiting and gastric distension and to prevent gastric acidic contents from entering the duodenum. Certain drugs are given to suppress gastric acid secretion. With resolution of the pancreatitis, patient resumes oral intake. For the patient with severe acute pancreatitis who does not resume oral intake, EN support may be started. The inflamed and necrotic pancreatic tissue is a good medium for bacterial growth. In patients with acute necrotizing pancreatitis, infection is the leading cause of morbidity and mortality. Therefore, it is important to prevent infections. Because many of the organisms come from the intestine, enteral feeding reduces the risk for necrotizing pancreatitis. Monitor the patient closely so that antibiotic therapy can be started early if necrosis and infection occur. Endoscopic or CT-guided percutaneous aspiration with gram staining and culture may be done. Surgical therapy. When the acute pancreatitis is related to gallstones, an urgent ERCP plus endoscopic sphincterectomy, severing of the muscle layers of the sphincter of Oddi, may be done. Laparoscopic cholecystectomy may follow ERCP to reduce the potential for recurrence. Surgical intervention may be needed when the diagnosis is uncertain and for patients who do not respond to conservative therapy. Those with severe acute pancreatitis may need drainage of necrotic fluid collections. This is done surgically under CT guidance or endoscopically. Percutaneous drainage of a pseudocyst can be done and a drainage tube left in place. Drug therapy. Several different drugs are used to prevent and treat problems associated with pancreatitis. Currently, there are no drugs that cure pancreatitis. Nutritional therapy. Initially, the patient with acute pancreatitis is on NPO status to reduce pancreatic secretion. Depending on the severity of the pancreatitis, EN is started. Because of the infection risk, parenteral nutrition is reserved for patients who cannot tolerate EN. If IV lipids are given, monitor blood triglyceride levels. In cases of moderate to severe pancreatitis, the patient may need enteral feeding via a jejunal feeding tube. When food is allowed, small frequent feedings are given. The diet is high in carbohydrate content because that is the least stimulating to the exocrine part of the pancreas. Suspect intolerance to oral foods when the patient reports pain, has increasing abdominal girth, or has increased serum amylase and lipase levels. Supplemental fat-soluble vitamins may be given. Nursing management, acute pancreatitis. Nursing assessment. Subjective and objective data that should be obtained from a person with acute pancreatitis are outlined in Table 43.21. Nursing diagnosis. Nursing diagnosis for the patient with acute pancreatitis may include acute pain, fluid imbalance, electrolyte imbalance, impaired nutritional intake. Planning. The overall goals are that the patient with acute pancreatitis will have 1. Relief of pain, 2. Normal fluid and electrolyte balance, 3. Minimal to no complications, 4. No recurrent attacks. Nursing implementation, health promotion. Major factors involved in health promotion are 1. Assessing the patient for predisposing and etiologic factors, and 2. Encouraging early treatment of these factors to prevent acute pancreatitis. Encourage the patient to cease alcohol intake, especially if they have had pancreatitis before. Recurrent attacks of pancreatitis may become milder or disappear if alcohol use is stopped. Encourage early diagnosis and treatment of biliary tract disease, such as gallstones. Acute care. During the acute phase, it is important to monitor vital signs. Hypotension, fever, and tachypnea may compromise hemodynamic stability. Monitor the response to IV fluids. Closely monitor fluid and electrolyte balance. Frequent vomiting, along with gastric suction, may result in decreased chloride, sodium, and potassium levels. Respiratory failure may develop in the patient with severe acute pancreatitis. Assess respiratory function, e.g. lung sounds, O2 saturation levels. If ARDS develops, the patient may need intubation and mechanical ventilation support. Because hypocalcemia can occur, observe for symptoms of tetany, including jerking, irritability, and muscular twitching. Numbness or tingling around the lips and in the fingers is an early sign of hypocalcemia. Assess the patient for positive Chvostek's sign or Trousseau's sign. Give calcium gluconate as ordered to treat symptomatic hypocalcemia. Monitor serum magnesium levels since hypomagnesemia may develop. Because abdominal pain is a primary symptom of pancreatitis, major focus of your care is pain relief. Pain and restlessness can increase the metabolic rate and contribute to hemodynamic instability. Opioids may be used for pain relief. Assess and document the duration of pain relief. Comfortable positioning, frequent changes in position, and relief of nausea and vomiting help reduce the restlessness that usually accompanies the pain. Assuming positions that flex the trunk and draw the knees up to the abdomen may decrease pain. A side-lying position with the head elevated 45 degrees decreases tension on the abdomen and may help ease the pain. For the patient who is on NPO status or has an NG tube, provide frequent oral and nasal care to relieve the dryness of the mouth and nose. Oral care is essential to prevent peritonitis. If the patient is taking anticholinergics to decrease GI secretions, the mouth will be especially dry. If the patient is taking antacids to neutralize gastric acid secretion, they should be sipped slowly or inserted in the NG tube. Observe for fever and other manifestations of infection in the patient with acute pancreatitis. Respiratory tract infections are common, which causes the patient to take shallow, guarded abdominal breaths. Measures to prevent respiratory tract infections include turning, coughing, deep breathing, and assuming a semi-Fowler's position. Other important assessments are observation for signs of paralytic ileus, renal failure, and mental changes. Determine the blood glucose level to assess damage to the beta cells of the islets of Langerhans in the pancreas. If patients have surgery to drain necrotic fluid or treat a cyst, they may need special wound care for an anastomotic leak or a fistula. To prevent skin irritation, use skin barriers, e.g. stoma adhesive, Caraya paste, pouching, and drains. In addition to protecting the skin, pouching allows a more accurate determination of fluid and electrolyte losses and increases patient comfort. Sterile pouching systems are available. Consult with a clinical specialist or wound, ostomy, and continence nurse, WOCN. Ambulatory care. After acute pancreatitis, the patient may need home care follow-up. Because of loss of physical and muscle strength, physical therapy may be needed. Continued care to prevent infection and detect any complications is important. Counseling about abstinence from alcohol is important to prevent the patient from experiencing future attacks of acute pancreatitis and development of chronic pancreatitis. Because nicotine can stimulate the pancreas, smoking should be avoided. Teach the patient and caregiver about the treatment plan including the importance of taking the required medications and following the recommended diet. Dietary teaching should include fat restriction because fats stimulate the secretion of cholecystokinin, which then stimulates the pancreas. Encourage carbohydrates as they are less stimulating to the pancreas. Teach the patient to avoid crash and binge dieting because they can precipitate attacks. Teach the patient and caregiver to recognize and report symptoms of infection, diabetes, and steatorrhea, foul-smelling fatty stools. These changes indicate ongoing destruction of pancreatic tissue and pancreatic insufficiency. The patient may need exogenous enzyme supplementation.